Hello, good morning, good afternoon, good evening, wherever you are. I am Dr. Rajat, and you have started watching our YouTube channel, The Fertility Gynecologist. It is in English, and we also have a Hindi YouTube channel, Gynek Didi and Gynek Wala. A request to kindly like the video, share the video, and subscribe to our both of channels. Today, we are going to talk about a very interesting topic, that is adenomyosis. What is adenomyosis? Why adenomyosis is important? Does adenomyosis affect infertility? Does it affect IVF? How to treat the adenomyosis? Fine. So first of all, what is an adenomyosis? So adenomyosis is basically a swelling of uterus in which there is a collection of blood inside the myometrium or the wall of the uterus. This wall of the uterus. Normally, to explain it in a simple terms, this is an endometrium. This endometrium normally comes out of the periods. In some females, this endometrium goes into the myometrium, and with every cycle later on, this myometrium, the endometrium within the myometrium, it swells under the influence of hormones, and during every period this swelling causes pain. It doesn't occur immediately, but it occurs after 5 years, 10 years, 20 years of the event. So what are the causes of adenomyosis? Does adenomyosis occur in every female? Usually it occurs in those females who have got 2, 3, 4 deliveries, either normal or caesar, who have got history of MTP pills, who have got history of miscarriages, DNCs, multiple DNCs or multiple myometrial surgeries. Sometimes it also occurs de novo, means without any history of any surgery, the adenomyosis occurs, and in those cases we do not have any cause of adenomyosis. So what are the symptoms? How a female of adenomyosis will present to me? Does a female come to me and tell me, "Okay, sir, I have adenomyosis"? No, answer is no. Usually, most of the adenomyosis have got severe dysmenorrhea or pain during menses. Sometimes as they grow older, say 35, 40, they also have excessive bleeding PB, menorrhagia along with adenomyosis. Some female only have dysmenorrhea, some have only menorrhagia, some have excessive dysmenorrhea but sometimes menorrhagia. Some have excessive menorrhagia but sometimes dysmenorrhea, and some females have both excessive dysmenorrhea and excessive menorrhagia. So the category differs. It may be a gross adenomyosis, that means it may be a generalized swelling of the uterus, or it may be adenomyoma, that means it may be a localized collection or localized swelling of a wall of uterus. Many radiologists, what I have found is they fail to differentiate between adenomyosis and a fibroid. They write fibroid in their reports when instead it is adenomyosis when we examine the patient. So most important thing is we do not go by the report of radiologists. Most of the times we see ourselves to make a diagnosis, because when we as a gynecologist are doing the ultrasound, we correlate the ultrasound finding with the history of the patient, with the symptomatology of the patient, with the LMP of the patient, menstrual cycle, how many issues does the patient have. So all those things, when we correlate, that is when we can make a diagnosis. My sir always used to tell me, in an ultrasound, your eyes sees what your mind knows. So by the time, before, when we take history in our OPDs for the patients who come with the complaint of dysmenorrhea or menorrhagia, we will make it a point in our mind to see that we have to look for adenomyosis, or we have to look for a chocolate cyst, we have to look for a pelvic inflammatory disease. These are the causes of dysmenorrhea, possibly. So most of the symptoms are lower abdominal pain, dysmenorrhea and menorrhagia, as I discussed. So how is an adenomyosis diagnosed? Earlier, about 20-30 years back, when the ultrasound use was, sonography was not so much prevalent, we used to diagnose adenomyosis by symptomatology and by doing a PV examination, when we used to say uterus is generalized bulky but no soft indentation suggestive of fibroid. But the definite diagnosis, nowadays we have got ultrasound and there are various diagnostic criteria on the ultrasounds. I am not going into the details, but you are able to see that mostly it is a posterior wall adenomyosis. Posterior wall thickness of myometrium is more than anterior wall thickness. There is a sun ray appearance. The myometrium is not homogeneous, it is heterogeneous. There are various echoic, anechoic shadows, and we can, the one who knows adenomyosis on ultrasound can definitely make it out that this is an adenomyosis. But having said that, the confirmatory diagnosis is MRI. There are various junctional zones and the myometrial zones, which is not important for a general public, but definite diagnosis can be made of on an MRI. So somebody was asking what is the difference between adenomyosis and an adenomyoma. Adenomyoma is a collection or a swelling at a localized part at any of the uterus myometrium level, while adenomyosis is the gross swelling, or there is no definite swelling at a single place, but a gross enlargement and the swelling of uterus. So that is the difference between an adenomyosis and an adenomyoma. There are different stages of adenomyosis, but for the general public, in the initial stages, the dysmenorrhea, the pain is occasional, maybe 1 or 2 days. There may or may not be menorrhagia, but as it progresses, as the multiple menses occurs, adenomyosis, you have to understand, it is basically a disease of a menstruating female. The moment the female goes into the menopause, the moment the menses stops, the adenomyosis also stops at that point of time. So if and whenever there is an inciting event or a event which gives rise to the adenomyosis, the symptomatology may not be there right then and then, but as the moment the female menstruates more, the more endometrium goes into the myometrium, the more hormonal effect of those endometrium which is in the myometrium occurs. After few years after those events, the symptomatology starts to occur, the pain, the bleeding, and all those kind of things. There is a question somebody has asked, is adenomyosis a serious and a dangerous condition? Well, it is not life threatening. It is not that if it is not treated, it may kill the patient or it may harm the patient, but the quality of life, we call it as DQLI, daily quality of life index of the patient, becomes miserable if it is a gross adenomyosis. There the loss of many man working hours. She is not able to do her work properly. Even the routine household chores becomes a tough. It is tough. It affects the quality of life. So, does adenomyosis affects infertility? Answer is both yes and no. In few cases, females do conceive with adenomyosis, but in most of the cases, adenomyosis does affect infertility. It affects the implantation, and especially the IVF cases. If there is a gross adenomyosis, we have to take extra care. There are extra injections need to be given, extra medicines which need to be given. We need to suppress the menstruation for a long time, for 2, 3, 4 months, and then maybe we can go for an embryo transfer. Like somebody, how does adenomyosis basically affect infertility? If the endometrium is being formed clearly triple line on an ultrasound, then usually the adenomyosis won't be a factor in infertility. But if endometrium is not clear cut triple line on the day of ovulation, then the chances are that it may affect infertility. It may affect because of the swelling in the myometrium, because there may the affect the blood supply to the endometrium by the radial and the spiral arteries may get affected, and that may affect the implantation of embryo inside the uterus, so that may affect the infertility. So, is it a hormone dependent condition? Yes, it is basically a estrogen dependent condition, and that is why when I said it is basically a disease of menstruating females, because for menstruation estrogen is required. The moment female lands up in the menopause, the estrogen levels of females are down, and that is when the growth of adenomyosis stops. It stops at that place, and that is how we, for all the medicines of the adenomyosis, we give an antagonist or a hormone to counteract the effect of estrogen, that is a progesterone, in various forms to treat the adenomyosis. Does adenomyosis get worse during ovulation? Yes. it gets worse during ovulation, because that is the peak of the estrogen level. Estrogen peak leads to the LH peak, and that leads to the ovulation. So around the ovulation time, if the females who have got ovulation, they get worse. Does it grow slowly? Yes. In most of the cases, it grows slowly. It is a slow, lingering growth over a period of years. Say, in our clinical practice, we find adenomyosis in females who have undergone previous 2 seizures, previous 3 sections, previous 3 cesarean sections, multiple MTPs, medical termination of pregnancies via a surgical route, that is suction evacuation, or a DNC, multiple DNCs, or even for those females who have taken multiple MTP pills. Those are the cases in which the adenomyosis is more. But if a 25-year-old female has undergone 2 cesarean sections, that doesn't mean adenomyosis will start occurring next month. It will take few years. After 5 years, 7 years, that is the time when the adenomyosis starts occurring. So how do you treat? Suppose a patient comes to me with case of lower abdominal pain or dysmenorrhea, and my treatment line would differ. A 20-year-old patient with dysmenorrhea or a 30-year-old patient with dysmenorrhea. 20-year-old is an unmarried female with no marriage, no issues, and 30-year-old female with two live issues, 2 deliveries, either normal or cesarean. The management of both the things would differ. The chances of adenomyosis in an unmarried girl who has not delivered any time are very, very less. She may have endometriosis. She may have primary dysmenorrhea. But a 30-year-old female who has dysmenorrhea, who has a lower abdominal pain during menses, the chances that she may be having adenomyosis are more. So how do I comfort that patient? First of all, if I'll make a diagnosis of adenomyosis, seeing the history, clinical examination, and ultrasound, and the first thing I normally advise to my patients is apply a heat pack on lower abdomen between the umbilicus and the pelvis. Apply any application of heat for about 30 to 40 minutes a day, and that has to be done daily. I'm not talking only when the pain is there, but if it is applied daily, irrespective whether the pain is there, irrespective whether the period is there or not, if it is applied daily for about half an hour, 40 minutes, then the chances that she may be having pain again during the next cycle would decrease by 30 to 40%. And believe me, this works wonders. Hot pad application, their electrical heat pads are available, which are filled with either saline or jellies. They work wonders. I personally do not recommend those hot water bag in which you have to first of all boil the water and then put the hot water inside. When the patient is having, female is having pain, she won't go there. It is very difficult to go and boil the water, and during the process of pouring the boiled water inside that hot water bag, sometimes itself leads to the burns on hands. And that material, we have found, it works for maybe a couple of months and then it does not work. Electrical charging bags are worth it. They are not very costly. They hardly cost 200-300 rupees. Just charge for 5 minutes. They remain well heated for about half an hour, 40 minutes, and they work for about 3 to 4 months. So that is good enough thing. So we have given the symptomatic management. We'll give her a painkiller SOS, either in the form of a cyclopam or a combiflam. Meftalspas for me, mefenamic acid as a painkiller in dysmenorrhea, I do not find it worth it. For me, cyclopam or a combiflam works best. One tablet, maybe 2 times a day, 3 times a day. The female has to take maximum for 2 or 3 days a cycle. And if the hot pad application is being done, maybe the requirement of that painkiller tablet would go away. Now, the further management of an adenomyosis, it depends whether the female wants for the children or not. Because as I said, it is a disease of a menstruating females. We have to stop menses for females for the proper treatment of adenomyosis. Earlier, there are cheaper options, there are slightly expensive options, and there are more expensive options. In the medical management of adenomyosis, first of all, we give a cheapest option, that is called as an oral contraceptive pill, hormonal pill, to suppress the ovulation, to suppress the formation of follicles, to suppress the formation of estrogen, and that in long term would very well help the females in the management of adenomyosis. But the problem with OC pills is they have to be taken daily, and most of the females in their minds have got this think that it may cause cancer, it may cause weight gain. These have got various side effects. So maybe we can, if the patient is not affording or if patient is willing to take it for long, we can start with the low dose oral contraceptive pills and they work wonders. Suppose it doesn't work, OC pill, or the patient is not willing, or there is a some form of a contraindication to take OC pills. Say patient is diabetic, patient is hypertensive, patient is having past history of MI, then we do not give OC pills in those cases. We can give a trial of progesterones. We can give it in form of an orethistérone. We can give in form of a desogestrel, any form of cheap progesterones which are available. Those also work very well. In last 7, 8, 10 years, a very good molecule has come, that is a third generation progesterone, which is called as a Dynogest 2 milligram tablet. Believe me, it is the most wonderful miracle tablet for adenomyosis. I am not doing an advertisement of Dynogest. I am not doing this video. Is not sponsored by any maker of Dynogest, but this is the very, very, very good drug. And this is very safe, taken one time a day. It can be taken for 5, 7, 10 years, especially useful for females of about 30, 32, 35, in which they are still going to be menstruating for about 7, 8, 10 years. If it is taken daily, 90 to 95% females would be having absolutely zero pain. Even the bleeding would stop in many patients. And it can be taken, the recent studies are there that which tell us that it can be taken for about 5 to 7 years. 7 years maximum they can be taken. The only problem with Dynogest is it is a relatively expensive molecule at this point of time, with most of the companies having tablets ranging from about 40 to 50 rupees a day. So the monthly cost of the patient to the patient comes to about 1200 to 1400, and it multiplied by 12, multiplied by 7 years. So most of the people are not willing to take a Dynogest. We can also give a depot-medroxyprogesterone acetate injection, DMPA injection. It can be given every 3 monthly for a period of 2 years. It will reduce the pain, it will reduce the bleeding. It basically leads to amenorrhea, and that leads to a relief of the symptoms. So somebody was asking, are there any exercises we can do for adenomyosis? I mean, there are no practical exercises as such which definitely help for the adenomyosis, but routine walking may be a very, very good exercise. It will improve the blood flow, and apart from the periods, the Surya Namaskar, all the yogas are very, very good. It will improve the blood flow to the uterus. It will increase the flexibility, so it will decrease the impact of pain which you might otherwise be having, but there are no specific exercises as such. Best natural treatment for adenomyosis, like I said, I mean, you can apply heat and just pray to God if you have completed your family that you get to menopause early, so that the symptoms of adenomyosis decrease at that point of time with the onset of menopause. But menopause will itself come with another sets of problems, so there is no natural treatment of adenomyosis as such. Non-surgical management of adenomyosis we have discussed. First is the oral contraceptive pill, second is progesterone hormones in any form, norethistone acetate or levonorgestrel, third is a DMPA injection, and last is a very, very good molecule which is a Dynogest. And recently the people have come up with the research that letrozole 2.5 milligram, if it is given daily, letrozole is a drug which we normally give for the ovulation induction in fertility patients, but the mechanism of action of letrozole is excellent. It is an aromatase inhibitor which stops the conversion of testosterone to estrogen, so the estrogen in the body decreases, and if it is given persist 2.5 milligram a day, 99% of the estrogen in the body is reduced, and the moment it continues for a period of long 3 months, 4 months, 7 months, it works wonders for most of the patients. So it is a new study. We will discuss as and when the results of the studies come. So the permanent solution of adenomyosis is hysterectomy. Unfortunately, it is a removal of uterus. It cures the patient of dysmenorrhea, it cures the patient of menorrhagia. But again, while making a decision for hysterectomy, we have to know whether the patient has completed a family or not. Unless the patient has not completed her family, we won't advise her to go for a hysterectomy, because it is an invasive thing and female cannot conceive after hysterectomy. there are few schools of thought who say adenomyomectomy, surgical management, but adenomyomectomy, you remove that local part of adenomyoma and then sew the uterus up. Now, I for one personally believe if the female does not want a pregnancy, her childbearing is complete and you have to undergo a surgery, then there is no point of keeping that uterus inside. Adenomyomectomy, A, it is a difficult surgery. B, there are no definite borders of adenomyoma as such. Like in a fibroid, there is a pseudocapsule. You open the pseudocapsule and the fibroid will pop up. But in adenomyosis, there is no definite border separating a normal myometrium from a adenomyomatous myometrium. So A, it will find it difficult. B, it is a technically difficult surgery. There is a lots of bleeding. And once you have removed the adenomyoma, to sew that kind of a dead space, it itself is a bit problematic. Even if you accomplish all those kind of things, why are you keeping the uterus for? I mean, do you want a child in the future? But if you want a child in the future, this adenomyomectomy scar would itself become a weak spot on the uterus, and that may give rise to rupture. There are chances of rupture uterus in the pregnancy. So all the IVF specialists, if you talk to the for the patients who have adenomyosis, they will never ever advise you for an adenomyomectomy. Rather, a good course of a letrozole with dinogest or a GnRH agonist. While talking about the management of non-surgical management of adenomyosis, one injection I forgot, that is called as a leuprolide or a decapeptyl depot, that is a GnRH agonist. What it does is it stops the FSH-LS secretion at this place, that is high, it acts on the hypothalamus pituitary axis. So it creates a state of pseudomenopause. It is usually given for every monthly for 3 months, 3.75 milligram dose for 3 months. It is not given beyond that. Earlier 11.7 milligram dose was given for every one injection for 3 monthly for 3 doses, but nowadays we give for 3 to 4 months maximum. It creates a stage of a pseudo menopause. It and does helps in creating the amenorrhea, and but you have to add back, give a estrogen and a calcium add back, because it creates the risk of an osteoporosis. So can one conceive with adenomyosis? Yes, definitely one can conceive with adenomyosis. Does conceiving with adenomyosis is easier or difficult? It sometimes is easier, sometimes is difficult, depend, because adenomyosis is not the only cause of infertility. There are other causes of infertility also. It can be a husband semen factor which is affecting, it can be a tubal factor which is affecting, it can be endometrial factor which is affecting, it can be a another cause of the female AMH is low. See, by the time the female has adenomyosis, she is already about 30. And in Indian females, what I have found, I get AMH done in almost all of my patients. So by that time, AMH is on the relative low side. In the moment AMH is low, that is one of the causes of unexplained infertility, which I have discussed in my previous video. So that may also be the causative factor. And secondly, I have found in my practice, people don't believe it, but secondary infertility is difficult to treat than a primary infertility, because in primary infertility female is relatively desperate. She usually does all the things, all the lifestyle dietary things we advise. But in secondary infertility means female already has a child before and she is wanting to conceive the next time. I mean, this is, I don't know, my Achilles heel. I find relatively tough to treat these females, because they have their motivation level is slightly less. They are not as anxious, as desperate to get a child like the time they were the first time. So it is relatively difficult. Also the age factor, the difference between, by the time the female gets ready for a second child after first child, it is she's already 5 to 7 years elder. So in females, 5 to 7 years elders means her AMH has already started decreasing more. So adenomyosis by itself doesn't cause infertility unless the female is having a gross PCOD and with adenomyosis is there, but it becomes difficult. So now comes to my favorite question: can I do an IVF with adenomyosis? Yes, you can definitely do an IVF with adenomyosis, but it has always to be a segmented IVF, a freeze-all policy. What we do is, first of all, we do the ovulation stimulation, we make the eggs, we do a pickup, then we freeze all the embryos, and then comes the most important part. Then we give a cocktail of either GnRH agonist depot in form of depot 3.75 milligram or 11.75 every. If we give 3.75, we give every monthly for 3 doses, or if we give 11.75, we give only once. We can or cannot, depending upon the severity of adenomyosis, what is the junctional zone thickness, what is the posterior myometrial thickness, we can add Dynogest along with it. We can also add some amount of letrozole. Again, everything is subjective, everything is individualized. And then we put patient in a state of a complete amenorrhea for 3 months. And after 3 months, once she gets periods, then we start doing a process of a frozen embryo transfer. If we do all these steps, then the chances of the success with IVF would increase. If we do not give a period of amenorrhea with GnRH agonist plus minus Dynogest, then the chances of success may not be more. A patient with an adenomyosis whom we know has an adenomyosis before she conceives, does she have a normal pregnancy? Well, in most of the cases, she'll have a normal pregnancy. What I have found is adenomyosis can lead to a preterm labor. Adenomyosis can lead to sometimes unexplained rupture of uterus, especially if adenomyosis is caused due to an undiagnosed perforation of previous MTP. See, sometimes what happens is whenever we are doing a MTP, we dilate, and either inadvertently or by a newcomer, sometimes the dilator goes through the myometrium, but it does not perforate completely, it perforates only slightly, and that heat heals by itself. But that incomplete perforation is a foci for adenomyosis in future, and when that female gets pregnant next time, that becomes, the healing is not proper, and that when the uterus expand, that may be a site of a rupture in pregnancy. I have seen 2 cases in my life with undiagnosed perforation who have ruptured later on. It is a foci of adenomyosis later on. So it is a high risk pregnancy. There are chances that the patient may need more amount of progesterones to counter the effect of estrogen in pregnancy. She may need more dydrogesterones, more support of progesterones in form of capsules, tablets, suppositories, injections. So, are there any things which need to be avoided while having adenomyosis? Medically speaking, there is nothing like that, but because it is a pro-inflammatory condition, there is a lots of inflammation in the body, and like I said to all of my patients, eat an anti-inflammatory diet, and most of the inflammation in our diet comes from 4 things: refined carbohydrate in any form, in form of potato, in form of maida, that is refined flour, in form of wheat, and in form of dairy, and sugar. These are the things we need to avoid. Any kind of dairy, sugar, jaggery, honey, potato, wheat, anything made from maida, toast, biscuit, pizza, pani puri, samosa, farsan, maggi, pastry, cake, bread, pasta, burger, you need to avoid. You need to take diet rich in antioxidants. You need to take diet which is rich in green leafy vegetables, fresh fruits, seasonal fruits, basically green, red, and orange. These are the yellow. These are the color vegetables you should be eating. Greens like palak, greens like amaranth, greens like methi, yellow like papaya, yellow and orange like carrot, yellow and orange like pumpkin, red like beet, red like tomato. So you have to eat diet rich in all these kind of things. Diet I have already discussed for the adenomyosis. Any fruit which is good for adenomyosis, there is specifically as such no fruit which is good in adenomyosis, but I have told what needs to be done. Does progesterone cure adenomyosis? An interesting question. Progesterone per se does not cure an adenomyosis. What progesterone would maximally do is to counteract the effect of estrogen on adenomyosis, and it will do a holding job. It will do a holding job. Symptoms may be managed sufficiently enough. That means there are no excessive debilitating symptoms to the patient. But there is no cure of adenomyosis. Only cure is permanent hysterectomy. And the definite diagnosis of adenomyosis is on histopathology on biopsy. Before that, what we do is a presumptive diagnosis. That's it. Can one live a normal life with adenomyosis? Yes, like I said, I've been using Dynogest for almost 5 to 7 years now, and I found excellent results with Dynogest. I appeal to the makers of Dynogest to kindly reduce the cost of Dynogest. I also appeal to the Foxy, that is our Federation of Obstetric Gynec Society of India, to appeal to the makers of Dynogest to reduce the cost so that it becomes affordable to most of the females. Because most of the studies, they say it is a very good for adenomyosis. It can be taken for 7 years. There is a absolute good safety profile, almost no adverse effects. It is the wonder drug for adenomyosis, provided you take from a standard company and a standard brand. How to increase fertility with adenomyosis? I have already mentioned. Hot water bag application would decrease the symptoms. Diet, avoid diet with pro-inflammatory things, refined carbohydrates. Take diet which is rich in antioxidants. Take few nuts every day. They contain omega-3 fatty acid. They are natural antioxidants. Is yoga good for adenomyosis? Can yoga cure adenomyosis? Yoga is definitely good. I have already discussed. It will reduce the symptomatology. It will reduce the pain of adenomyosis. But whether yoga can cure adenomyosis, it remains to be seen. I'm not too sure. It will manage the symptoms to a greater extent, but the permanent cure, like I said, is in the menopause or removal of uterus, but it will definitely not cure the adenomyosis. Does adenomyosis spread to other organs? No. But endometriosis and adenomyosis are like brother and sister. If there is a endometriosis, adenomyosis is bound to be there sometimes. They usually coexist because the pathology is almost the same. Endometriosis is the presence of endometrium inside the peritoneal cavity, and adenomyosis is present of endometrium in the myometrial cavity. And females, what I have found is they both usually are together, but it does not usually spread to the other organs like the endometriosis does. What shrinks adenomyosis? Anything which leads to the menopause, anything which leads to the decrease in the estrogen level of the body, like a premature menopause or a normal menopause or a surgical menopause, would shrink adenomyosis, would decrease the chances of adenomyosis. Does cesarean section increase the risk of adenomyosis? Answer is yes. Not in all, but in some. See, what happens is, in cesarean section, we put a scar at the lower uterine segment. That means we are cutting the myometrium and the endometrium. And the endometrium or the decidua, which is there beneath the placenta, while we are sewing, how much so we may avoid the decidua in our scar. Some amount of decidua would definitely go inside the myometrium. Also, during the time when the uterus is this much big at the time of delivery, there are sinuses from myometrium to the endometrium which are supplying the placenta. Those sinuses are open. Through those sinuses also some amount of decidua can go in, and that is when the adenomyosis can start, and that can occur in the normal delivery also. But in normal delivery, since there is a less invasion, less cutting of the myometrium, the chances are less, but it can occur with multigravidas patients. So this was our video about adenomyosis. If you have any comments, any questions, please share with us. We will try to answer them. A sincere request, please like the video, share the video, and please subscribe to our channel. Thank you.